Hey everybody, this is Eric with FlightBridgeED and welcome back. We're going to start on podcast number 2 of the RSI series. Did the first podcast on the pharmacology and how it relates to our patients. In this podcast I want to go in through the whole procedure. I want to talk about the protocol in general and how we can be more efficient for our patients, and just talk about risk factors, things that can kind of get you into trouble, and strategies that will actually make this process a lot easier. So let's first talk about what RSI is. Multiple protocols that I've worked under, it's really named different things. It's either rapid sequence intubation. I've heard it as facilitated intubation. I've also heard it as drug-assisted intubation. Regardless of what it is, though, basically what we're doing is we're inducing unconsciousness via paralysis, and we're doing this by giving a paralytic, short-acting and a long-acting paralytic in most circumstances. We're doing this because we have a patient that obviously has a airway failure of some sort, or their clinical course is kind of heading down that road. So we need to always be thinking about multiple aspects. Can they protect their airway? Obviously, they have a gag reflex, or you wouldn't be using drugs to induce paralysis. Other aspects of it, do they have a potential to vomit? Remember, if a patient vomits, their mortality and morbidity rate increases by 50%. And I don't care how good you are as a clinician, if you have a patient on a backboard, let's say, and they start to vomit, even if we're ready for it, there's no way we can suction their airway out or turn the backboard quick enough to stop that aspiration from happening. They're going to aspirate some contents into their lung fields. So we really are doing our patient a disservice if we're not thinking along those lines. So we need to be identifying patients that potentially could be better off by utilizing the RSI protocol. We need to be looking at, again, their clinical course, how this is going to benefit them, oxygenation-wise, hemodynamic-wise, etc. So let's talk about a few different circumstances of why we would use it. Obviously, in a trauma situation, if you had a head injury patient, they're breathing extremely fast or tachypnic from maybe a brainstem injury, they're clenched, they've got vomitus or blood in their airway. That's a circumstance where we would definitely want to RSI them. Any oxygenation or ventilation failure, in a medical patient, so we're talking about pulmonary edema patients or COPD patients. Those patients oftentimes go down a clinical course where they become so hypoxic it starts to affect their hemodynamic status. Remember, oxygenation equals cardiac output, and that's the Fick principle. So if we always try to correct oxygenation, a lot of times if we optimize oxygenation in the right way and we're aggressive in that aspect of patient care, we're going to have a benefit, and we're going to see that benefit in the cardiac output, the blood pressure, etc. And then anticipating the clinical course. What I mean by that is, if you don't intervene in their airway, is there something going to happen that's going to take you down a road where you're going to kind of be caught with your pants down? So I always believe that you need to kind of be aggressive in that area. I don't like to be caught like that. I don't want something to happen where I'm kind of behind the 8 ball. So I'm always a component of, let's say an alcohol intoxication or a drug overdose. Maybe they have a GCS of 12 or 13, but they really can't protect their airway, or their mentation is going to continue to decrease where they could vomit and aspirate. Those are the types of patients where I feel like even though they've got a good patent airway and they're able to maintain it at that point, it's going to be better for them to take their airway, intubate them. Once you get them to the definitive facility that you're taking them to, if they choose to extubate them, they've got more people. They've got a lot more avenues to monitor them. So if they want to extubate them, then they can do so. But what I've found is, especially in these larger facilities, they do the same thing. This is exactly the approach they take. So the big aspects of RSI is preparation. We need to prepare from the first time we have the call. So whether you're a ground paramedic or you're you're a flight crew, flight nurse, flight paramedic on a helicopter or fixed wing, we need to prepare probably 10 minutes prior to even making patient contact. And so what I mean by that is, let's say you are on a helicopter, you're going to a scene flight, and as you're going to the scene flight, you get some patient update, you call for LZ instructions, they give you a patient weight, estimated patient weight. At this point, we can start looking at our drug dosages. We can estimate drug dosages based on that patient weight. The other thing you can do is you can obviously get a quick report. You can decide if the clinical course or what the EMS provider on scene is telling you is going to probably make you choose to RSI this patient. So a lot of times that decision is made for me in the helicopter. I've got that in the back of my mind. Obviously, when we get on scene and we make patient contact, we can, justify our thought process and then move in that direction, or we can, move away from that direction. So the big aspects of preparation, again, you need to start thinking about your drug dosages. Another quick way to do that, where you can prepare your drugs in advance, is just using certain syringes for each medication. And so what I like to do is, I learned this a few years back, it's excellent, is certain syringes are meant for certain medications. So a 3 cc syringe is going to be for Versed, a 5 is going to be for fentanyl, 10 is going to be for succinylcholine, 20 cc will be for the etomidate, and then a 10 cc flush is going to be for your vecuronium if you choose to use a post-intubation paralytic. So if you draw up the whole vial of each one of those medications in the syringes I just stated, you don't need to label them. You don't need to, put tape around them or anything. You can put them in your flight suit. When you get out of the helicopter, get to the patient, you already have these medications, and then again, you've got these drug dosages in your head, and you can just administer what you need to administer. So it's a very quick way to prepare on the fly. You can do this within a few minutes. Obviously, work as a team if you're a flight crew. So let's talk about, you get on scene, you make patient contact. We need to do a thorough, quick assessment. Remember, when we talk about flight, we talk about helicopter EMS, we're being utilized for quick transport, right? So a lot of these areas that I've flown are very rural areas. The EMS agencies would have, an hour and a half drive to a major trauma center or a high-level facility that can handle different cardiac and stroke symptoms. So helicopters are utilized for quick access, right? So we don't want to sit on scene for 10, 15, 20 minutes. That's pointless. That kind of defeats the whole purpose. So there's a few circumstances, obviously, where we're going to try to probably manage that airway on scene, but that's very far and few between, really. And most helicopters that I've flown on, all but one, you can manage somebody's airway, you can intubate them in flight with no problems. The only aircraft that I could say that is very difficult, and I would probably choose to do it outside the aircraft, would be a BO-105. But all other aircrafts that I've flown in, intubation has been very easy in those aircraft. So when we make patient contact, obviously we're going to assess their airway, and the quickest and easiest way to do that is something called the Lemon Law. And so the first aspect of the Lemon Law, there's 5 categories, is look. You're going to look at your patient, you're going to do a good quick assessment, look at their airway, look at their facial structures, just look at everything, kind of get a good idea of what you've got. The second thing is going to be what's called a 3-3-2 rule, and that 3-3-2 rule is basically you're going to put 3 fingers in their mouth, you're going to put a couple fingers under their chin, and you're going to, basically, it's hard for me to explain via podcast, but you're trying to see how wide their mouth can open. You're looking at their neck and their chin and their structures. Do they have a no neck? Do they have a long neck? And so are they going to be an anterior intubation? Maybe more difficult. The third aspect is going to be the Mallampati score, and the Mallampati score is going to be used only for those medical patients that are already sitting up. They have to be conscious. This is not going to work if they're laying down, if they're on a backboard, or they're unconscious. So you're going to have them sitting up. So a COPD patient, a CHF patient, maybe they're exasperated, they're fatigued, you choose to intubate them, or you're going to go down that clinical course of intubation and RSI. And so what you're going to do is you're going to have them open their mouth, stick out their tongue, and you're trying to visualize the back of the throat. You're looking to see if the uvula is in complete view, and you're looking at that tongue, and you're making sure the tongue isn't big and bulbous, and that you can't see the back of the throat. So a grade 1 is going to be used where you can see all the structures in the back of the throat, the uvula, etc. A grade 4 would be a person where the tongue is so large that you can't see any of the structures in the back of the throat. And so a grade 4 obviously is meant to tell you that you could have a difficult time with intubation. It's going to be a little bit more troublesome, possibly. I will say that I've had grade 4 intubations based on my assessment, and I've gotten in, and the intubation's been easy. So obviously it's not 100%, but it kind of keeps you really looking at your airways consistently, and it allows you to realize that it could be a difficult intubation. I guess what I'm trying to say is it's a good thing. Continue to do it, even though it may not be 100%. The fourth thing is going to be obstruction. You're going to look in the throat. You're going to look in the mouth. Make sure there's no broken teeth, no dentures that have fallen back in the throat, blood, emesis, etc. And you're going to clear that out. And then the fifth thing is going to be neck mobility. Whether they're an elderly patient that's has no neck mobility, or you have a trauma patient that's on a backboard that's strapped down, that's going to possibly cause you some difficulties in your intubations. So let's talk about that. If you have a patient that's a trauma patient that's on a backboard, and you get on scene and you do this Lemon Law assessment, and you realize that they're probably going to be a difficult intubation, you need to decide at that point if you want to remove the C-collar, remove the head blocks, and do manual stabilization from the front side, from the chest side. And what I always say is put yourself in the best situation to succeed. The airway is number one. Obviously, we want to maintain good C-spine stabilization, but airway is number one. So put yourself in a position that allows success. The other thing is to put your patient in a position that also allows success. And obviously in a trauma patient it might be difficult if they're on a board, but if you line up your shoulders, the top of your shoulders with their earlobes, it's been shown that puts the patient in a good neutral inline position, and it really helps those difficult airways, maybe that are more anterior. So if it's a medical patient and you're unable to see that, where your earlobes are at your shoulder blades, maybe pat under their torso, kind of like what we do with a pediatric patient. So we're preparing, we're assessing our patient, we're talking to our partner. At the same time, our partner is going to be putting the patient on a monitor, making sure your SaO2 is on, and obviously we need a good patent IV. If you can get more than one, that's great, but for purposes of an RSI, if it's an emergent situation, one IV is all I'm really concerned about at that point. Just make sure it's working and flowing. If you're having difficulties with peripheral IV, you get in the back of the ambulance and you realize that this is a critical situation. Patient's decompensating, they need rapid intervention. Skip the peripheral IVs and go straight to an IO. Get that. That's a definitive IV access, and it's excellent, it's quick, and we have that capability now, so utilize that. Remember, if you're going to use an IO, that you're going to need to push the fluids through a pressure bag. If they're conscious and you're starting to push that, it's always kind to give 20 to 30 milligrams of lidocaine in that port before you start pushing fluid, because it's very painful. So at this point, we are at the pre-oxygenation stage. So we've decided we're going to intubate. We've done a good, thorough airway assessment. Our partner's getting all of our other equipment ready. You're already getting your laryngoscope out. Pick whichever blade you're more comfortable with. I always go with a Mac 3. I'll get a Mac 4 out just as a backup. Get your E2 tube out. Get all that stuff prepared. Make sure your suction unit is ready. If you're in an ambulance that you're not familiar with, look up at the board on the right-hand side there and make sure you know where the suction button is. Make sure your canister's hooked up. Make sure you have all that equipment available. You don't want to be doing that when you get in the airway and realize you've got a throat full of vomit or blood. That's kind of a poor time to be thinking about suction. So at this point, we need to start thinking about pre-oxygenation. And here's my big thing on that. We're all taught BLS procedures on good BVM management. We're taught single rescuer and dual rescuer. And I know a lot of the companies out there, I know my primary employer, we teach two-handed BVM management with two providers. That's just better. It's beneficial. You get that good mass seal. You have some people that have small hands that can't do a single mass seal. So they teach a two-person technique. But with the induction of paralytics that we're going to use, especially the succinylcholine that we'll talk about here shortly, one of the side effects of that is fasciculations. And when we over-bag our patients, a lot of times in these situations, people are kind of a little bit excited. You may have a provider that's never been in this situation before, and that's fine. We were all new. We were all learning, and even experienced providers, we do this. We don't even realize it. We start bagging way too fast, and we push all this gastric air or all this air into the stomach, and we start filling up the stomach. Well, that's bad for multiple reasons, obviously, especially in a pediatric patient. You just don't want to do that. So there's better ways to pre-oxygenate your patients. And I'm not saying to use this technique on every patient. Obviously, there may be some patients where we need to bag them. They need really strong positive pressure. But I would say 9 times out of 10, the way I'm going to talk about here is very much adequate. So what I like to do is I learned this a few years back, and I thought it was a great technique, is use a nasal cannula, put the cannula on them at 12 to 15 liters per minute. So you have a cannula running at 12 to 15 liters per minute, and then you're going to grab a non-rebreather and you're going to put that on them as well. And just between those two sources of oxygen, they're going to be well oxygenated. So at this point, we've got our oxygenation going, and it frees up somebody. They can sit there and they can work on, again, preparing their equipment, making sure everything is going all right. They're helping their partner, and you're talking. Remember, this procedure isn't going to last more than 10 minutes, so things have to be done very systematically. You have to talk and communicate, and there's not going to be any wasted time. So at this point, we need to start talking about the pre-medication. We've already drawn up all of our medications, like I said in the beginning of the podcast, but now we need to start applying those. And so we're going to kind of go over the different medications. We're going to go over, again, in a maybe not as in depth as we did before, but we're going to go over why we give different things. So the first medication, again, is going to be lidocaine, and lidocaine is going to be used to blunt that ICP, and it's remember as a response to laryngeal and stimulation when we intubate. It's been shown that it could potentially increase ICP. So we want to try to blunt that. We want to block that, especially in the patients that have head injuries already or stroke patients. Those patients need this medication. You're going to find that most protocols, though, don't specifically tell you have to do this. It's going to kind of be the clinician's own judgment to do this. So I tend to give it, if I have time, I'll give it on all patients. If I'm kind of in a rush, based on their clinical course, I'll probably just give it for those head injury and those stroke patients. The next medication is going to be atropine, and remember, atropine is going to be used on all adult patients with heart rates less than 100. Some protocols may say 80, and then all children under, it could be 8 years old, it could be 12 years old, it just depends on the protocol. Some areas say a child is 8 years old and under, others say up to puberty. So whatever it is, I don't think you're going to be wrong by going that route, and it might be safer just to go to 12 years old. You're always going to use it, again, if for some reason you give a dose of succinylcholine and you've got to give another dose. I haven't had this happen to me, but if, let's say, it didn't work, you had trouble with the intubation or whatever. There could be different circumstances. You're always going to want to give a dose of atropine in that situation as well. So your dosing range, remember, is 0.02 milligrams per kilogram. The dose, like I said, is a minimum of 0.1, but the average dose is going to be a half milligram of atropine, just like you would for symptomatic bradycardia. And you want to probably give this 2 to 3 minutes prior to intubation. So at this point, we've given our lidocaine, we've given our atropine, and we need to start thinking about our sedation, our induction agent. And so there's quite a few induction agents. We also need to be thinking about our narcotic. And so oftentimes I'll give a narcotic prior to the induction agent, and we can talk about that real quick first. And so the best narcotic that we have at our disposal is fentanyl. And fentanyl is a very potent analgesic. It's a great sedative in higher doses. It's got rapid onset, but it's actually short duration, so it wears off quickly. The effects can obviously be reversed with Narcan. We always carry Narcan, so if you gave a little too much or you had some poor side effects from it, we can always reverse that if we need to. Standard dose for RSI, though, is 2 to 3 micrograms per kilogram, so you can imagine that's a big dose. If you want the 3 micrograms per kilogram dose on an 80 kilogram patient, that's 240 mics. Remember, fentanyl is very stable on the blood pressure. It's an excellent medication for pain, and again, in those high doses, you're going to have great sedative effects. So always give a nice dose of fentanyl prior to intubation. Remember, intubation is extremely painful. Imagine having that laryngoscope blade in your throat, and somebody lift it up as hard as we do sometimes. And then once the intubation's completed, you have this big old tube back there. So, and then in addition, you have the trauma patient that's already significantly hurt, broken bones, etc. So a nice dose of fentanyl is excellent in this situation. Once we've given the fentanyl, obviously, like I said, it's got some sedative effects. We want to give our induction agent, and the most popular induction agent now is etomidate. And remember, that's a non-barbiturate hypnotic, very rapid onset. Excellent for patients with ICP because it does drop ICP a little bit. It's very stable on the blood pressure. And the standard dose for that, again, is 0.3 milligrams per kilogram. And what I do, again, is I start with my patient weight in kilograms, and I divide that by 3, and that gives me my etomidate dose, and I will round down or up based on the standard rounding rules. So a 100 kilogram patient is going to be 33 milligrams, rounded down to 30 milligrams, and that's going to be your etomidate dose. So at this point, we've given our lidocaine, we've given our atropine, we've given our fentanyl, and we've given our etomidate, and you can imagine that's a lot of medications, right? And you're not going to really probably see the effects of the lidocaine and the atropine, obviously, but the fentanyl and the etomidate, that's a lot. You're giving some big doses. There could be the potential where you can intubate the patients at this point. For purposes of this presentation, though, we're going to go all the way through the protocol. What I'll tell you about that is, yes, there's arguments of, less is better. I'm only going to stop at the etomidate. If I can intubate them with the etomidate, that's great. I guess I really don't have a problem with that. Studies have shown, though, with patients with failed airway attempts from providers, it's better to go through the whole protocol. And a lot of times those failed attempts were due to not going through the protocol completely. So some agencies that I've worked for mandated you went through the whole protocol. Others, you can just do what you need to do to get that intubation. So that's going to be protocol specific, and you'll just have to know your protocols. All right, so we've given our etomidate now, and now we need to start thinking about our paralytic. And so let's talk a little bit about paralytics again. Remember, we have 2 different types of paralytics. We have depolarizing paralytics and non-depolarizing paralytics. And the standard paralytic for induction that is most common is succinylcholine. And succinylcholine is a depolarizing paralytic, and remember, it's non-competitive. So what happens is succinylcholine is made from 2 acetylcholine molecules, and we give that medication, and the acetylcholine floods those muscle neuron channels and fills those receptor sites up. It doesn't allow any more acetylcholine to get into these receptor sites. It causes a massive firing of all those muscle channels, and that's what causes those fasciculations. So that's where you get the rippling of the skin all over. That's where you can have the problems with vomiting if you have a patient with a lot of gastric air in and maybe contents. So remember, succinylcholine is a medication that is very short acting. It's very rapid onset as well, and onset's going to be about 30 to 45 seconds. So I've used succinylcholine many times. I think it's an excellent medication. It's kind of been the gold standard for years and years. 30, 40, 50 years. The standard dose is 2 milligrams per kilogram. And, I've seen it at 1 milligram per kilogram, but for the most part, that 2 milligrams per kilogram is standard. Remember, it's supplied in a 10 ml vial, so it's 20 milligrams per milliliter, and so that's very easy to kind of figure out. Remember, with succinylcholine, though, there's quite a few side effects. There's some contraindications that we need to talk about. The big contraindication that we need to think about is obviously burn patients greater than 24 hours. You can have a huge potassium shift, so you don't want to use it in that situation. It can cause malignant hyperthermia, and malignant hyperthermia is a bad thing. Basically, it causes an influx of calcium in all these channels, and patients that are predisposed to this, which they may not know, it can cause a massive temperature rise, and that's obviously very ominous. I think there's like a 60% mortality rate in those situations. It can cause masseter spasms. That's more seen in children. You don't want to use it in patients with penetrating eye injuries, or obviously you don't want to use it in a patient that's very hyperkalemic already. So obviously there's a lot of little side effects, contraindications to succinylcholine. So you got to just watch it, know your medication, know your patient, and just kind of do the best thing for your patient. So at this point, we've got our succinylcholine. We've decided that we're going to utilize that as our paralytic. And again, we're going to look at all these contraindications, and we're going to decide. If, let's say, we decide we don't want to give our paralytic or the succinylcholine as our paralytic, there's other paralytics that we can use. Most places carry, I know flight-wise, most carries rocuronium and vecuronium, and both of those paralytics are competitive, or that are non-depolarizing neuromuscular blockers. So remember, the way that those paralytics work is they block those receptor sites, so that no acetylcholine can get into those receptor sites. So that's how it doesn't cause fasciculations, and it doesn't cause any muscles firing. So that's how it induces paralysis. Rocuronium and vecuronium are both intermediate paralytics, so their onset is maybe a little longer, a minute and a half, but the onset is going to be 30 to 45 minutes, with rocuronium kind of being less than that. I think it's 25 to 30 minutes. So if you decide to go that route, rocuronium, even though as an intermediate paralytic, the onset is longer. I've heard the argument many times is, we use succinylcholine because if we can't get an airway, it's going to wear off in 3 to 5 minutes. Well, that's kind of hogwash. Remember, you have a backup airway, you have a king airway, you have a combi tube, and that's kind of ridiculous. If you don't get the airway after a few temps, you need to be putting a backup airway in, and it doesn't matter if you've got succinylcholine on board or you have rocuronium or vecuronium on board. It doesn't really matter. Just get an airway. And then if the patient's got a really poor airway, or there's massive facial trauma or whatever, then we need to be going to a surgical airway. So you need to be prepared to go down that clinical route if you need to. All right, so purpose of this, we'll say we're going to give the succinylcholine. There's no contraindications that you've seen, and so we're going to give, again, the 2 milligrams per kilogram. At this point, we need to be talking to our partner, right? So our partner never wants to give medications without talking to you. That's just not good. Whether you're working with an EMT partner on an ambulance or you're working in a hospital, everything has to be done communication-wise. We don't want to ever do anything without talking. Paramedics that are working on an ambulance, if you're working with an EMT, teach them how to do things. Teach them how to drop the medications. Obviously, they're not going to push the medications, but I worked with a partner in Oregon. His name is Wayne Morris, excellent partner. Ran a lot of calls, thousands of calls with him. We worked excellent as a team. I taught him how to do, a lot of things that, you learn in paramedic school. Obviously, he wouldn't perform those procedures or give those medications, but he would draw things up. He would do, set up the 12 lead for me. He would do different things, and it really helped me out, helped our patient care out, and it taught him. He ended up becoming a paramedic. He's an excellent paramedic now, and has even become a flight paramedic. So, utilize your resources. Teach your partner. If you're a flight crew and you're working with another nurse or paramedic, again, communicate with each other. So at this point, we're gonna push our succinylcholine, and when we do that, we want to make sure we push on hold cricoid pressure. So I'll have another provider holding cricoid pressure, and obviously the medication is being pushed. You're going to wait. You're going to make sure that the medication takes full effect, and you're going to do your intubation. While I'm doing my intubation, I'm always calling out my structures. I'm sweeping the tongue to the left. I'm placing the blade in the vallecula, and I'm telling my partner what I'm doing. I'm telling him what I'm seeing. Because if you do have a failed airway attempt, you should always change something on your next attempt, whether it be a blade, a technique, if you're going to use a bougie, anything like that, or if you're going to switch roles. So it's always good to tell that other person what you've seen. So the other area that I do is I'll actually manipulate my own cricoid pressure. So I've got somebody holding cricoid pressure. I'm going to put my hand on their fingers, and I'm going to manipulate the vocal cords into position. And it's a very quick, easy way to visualize the vocal cords quickly. Once I get them inside, I'll have them hold that same pressure, and then I'll intubate the patient. Once we've intubated the patient, obviously we're gonna secure the tube, and we want to mark where the tube is at the teeth. Remember, you're never going to do that at the lips because the lips can swell, they can change. It's not going to give you a good location that's set. If they don't have any teeth and they've got dentures, or you've removed the dentures, then do it at the gum line. Another way to kind of identify that you haven't placed a tube too far is whatever your tube size is, multiply that by 3. So if you have a 7.0 tube, times that by 3, that's 21 at the teeth. Excellent way to kind of double check yourself that you maybe haven't put it in right main stem, and that's the gold standard way to confirm for a child. So 3 times the tube size is going to give you an idea. Obviously, it's not 100%. People are all different, but it's kind of going to give you an idea that you're in the right spot lengthwise. So at this point, we want to secure our tube. So we're working as a team. In the hospital setting, you're going to use a tape probably. They don't like to have any occlusion of the mouth. They want to be able to see if there's any secretions coming out. But in EMS, we use what's called a Thomas tube tamer, and we utilize that. It's got a bite block. You're going to put that on. You're going to secure the tube. It holds the tube in place, and you secure that around the head, and it's an excellent way to secure the tube. Obviously, in the EMS realm, helicopter, fixed wing, whatever, you want to guard that tube with all costs. You don't want to lose that tube. So anytime you move your patient, remember to stop bagging them. Don't allow anybody to touch the BVM. Don't allow anybody to touch the tube, because people can trip. Things can get caught on it. Anything like that, you don't want to do that. I've obviously had that happen before. I've actually, on a very critical patient one time, we landed on a roof of a hospital. It was very windy. I told a couple of the providers that were helping us unload from the hospital to stop bagging. This one individual didn't listen to me, and she tripped or hooked on something as we were exiting the aircraft, and it dislodged, ripped the tube right out, and I had to re-intubate the patient on the pad. So obviously that didn't make me very happy. It didn't need to happen that way. If we just all work as a team and we do what we're supposed to do, things like that won't happen. The other aspect of intubation that we want to protect the airway is all patients that are intubated should have a C-collar on, regardless if they're a trauma patient. This is even more so for pediatric patients. Remember, pediatrics have a very large head. Their head flops around real easily, and so a C-collar on any intubated patient is really going to help you secure that airway, and it will not allow the patient to have the ET tube dislodge. So if you go into a hospital and it's a non-trauma patient, just explain to them why you have the C-collar on, because it'll probably confuse them. And then once you explain why you do it, they'll be happy. All right, so we've secured our tube. Once we have our tube secured, we got to verify tube placement, and obviously this is going to happen immediately after intubation. So the gold standard way is going to be doing it through end-tidal CO2 capnography. And so end-tidal CO2 capnography is going to be used for seeing a good waveform, and it's 100% indicative of tube placement. There's no chance that it's not going to record a good positive tube. And obviously there's other ways to confirm that. You're going to look at condensation in the tube. Did you pass it through the vocal cords? And do you have good lung sounds and no epigastric sounds? But the first thing you should be doing is putting that end-tidal CO2 capnography on. It should be prepared prior to intubation. I always have it sitting on the chest to where right when I intubate, I'll put that on and I'll have somebody bag them. If your agencies don't have end-tidal CO2 capnography at this point, they need to be getting it. It really is the gold standard. I know in the operating rooms in the hospitals, it's against the law. It's federal law to have that for any intubated patient. So that really is the gold standard. If you think litigation-wise, listening to lung sounds, listening to epigastric sounds is just an assessment finding. You can't prove that in a court of law. It's your word against somebody else. But if you have a end-tidal CO2 waveform that's printed out on an EKG strip, you can prove that you had a good tube. Another thing that I want to say is when you go into these receiving facilities, and I'm not going to pick on them. I'm not saying that anybody's to blame, but things happen. You're moving a patient over from your gurney to the bed. People are moving quickly. Blood pressures are up. Everybody's excited, and ET tubes get pulled. They get dislodged. So what I found is when I roll into the room, regardless if it's a trauma center or whatever, is I always make sure I hit print on my monitor. I print off a strip immediately when we get in there to prove that I had a good tube, because inevitably you're going to get blamed that you didn't have a tube at that point. So that's just proof. It's just protecting me and my partner. At this point, we're going to go through and we've got to move our patients to the ambulance, or we need to move our patients into the helicopter, or if we've decided to take care of this airway in the helicopter or the ambulance, obviously we're going down the road. So again, anytime you move your patient, you need to document on your chart, that you've verified end-tidal CO2 capnography, you've verified lung sounds every time. And we want to do that to protect ourselves again. Remember, you document anything you can, and you never know if a chart's ever going to be pulled. So at this point, we need to start talking about post-sedation management, or if we're going to go with a longer-acting paralytic post-intubation. So here's my thing on that. You have 3 different drugs to use, primarily, and the standard drug to use for sedation and post-intubation management is going to be Versed. And Versed is an excellent medication. It can also be used for induction. If you're an agency that doesn't have etomidate, you can definitely use Versed, or you can use propofol, like I said in the first podcast. Obviously, the standard nowadays is etomidate. But if we're talking about post-sedation management, the standard pretty much now is Versed for post-sedation. And so what I like to do is I like to give 2.5 milligrams every 10 minutes or so, and just kind of look at your patient. Remember, Versed can actually drop your blood pressure quite a bit, so you can tailor that dose down. You don't have to give 2.5, but you want to be giving sedation consistently. You want to be evaluating your patient, and regardless if you're in a helicopter or you're in an ambulance, assess. Don't stop doing that. Now, I will say, flight crew members, your assessment skills in a helicopter are going to be quite a bit different than they are in an ER or an ambulance. You're not going to be able to visually have the same cues or the same senses that you've had in those other arenas. You've got a helmet on. You've got the patient covered in a blanket. You just can't hear lung sounds. So you have to rely on other things. So I guess what I'm saying is just kind of watch things. Watch their blood pressure. Watch their pulse rate. If they're on a ventilator, which I highly recommend, placing all patients, especially helicopter or fixed wing, on a ventilator in this setting. You can see if they're overbreathing the vent. You can kind of tell by their respiratory flow patterns how they're doing. So 2.5 milligrams every 10 minutes or so. The next thing we want to be doing is we want to be giving pain management. Remember, this is a very painful procedure. Intubation is very uncomfortable. People don't like that. So giving a good pain management dose of fentanyl every 5 to 10 minutes is an absolute thing you need to be doing. So let's say we have a low blood pressure, in these hypotensive patients, the hemodynamically unstable. Hopefully, oxygenation wise, you're optimizing that. You may have some improvement in hemodynamic status, but never withhold sedation or pain management because they've got a low blood pressure. There's other things you can do to help that. There's no patient that I can think of that a fluid challenge isn't going to benefit. Even CHF patients that are filled up, they're still going to be vascularly dry, and they're going to respond well to 250 to 500 cc fluid challenge. So, give a fluid challenge. Give some fluid. In a trauma situation, obviously we want to give fluid. We don't want to over fill somebody up. You don't want to. That's kind of going to be another podcast, but. Give some fluid. If it's a medical patient and they're that sick and you need to be given sedation, then start them on a pressor. Put them on Levophed. Put them on dopamine. Do something, but you have to be given sedation. There's no circumstance where a patient's going to benefit by not doing that. They're going to actually do worse without sedation. Their oxygen demand is going to be up. They're going to be very uncomfortable. It's just not going to be a good thing. So you want a nice, relaxed patient. All right, so giving the Versed and giving the fentanyl, most of the time, will keep the patient sedated enough. You don't need to give a post-intubation paralytic. I mean, there are obviously circumstances where you'll have to, but I think if you're on top of your sedation and you're on top of your pain management, the patient's going to do very well in that setting. If you have a patient that maybe is on chronic benzos, chronic narcotics, and they burn through those medications, they don't respond well to them, and they're still maybe biting at the tube or grabbing or a little bit uncomfortable, then at that point, you can obviously up your sedation dose, or you can up your fentanyl dose. But most of the times that's not going to work, so you need to go with that long-acting paralytic. And so that's, remember, going to be vecuronium, or you could use the rocuronium, but vecuronium is kind of the gold standard. And remember, the vecuronium dose is going to be 0.1 milligrams per kilogram. It's a longer-acting paralytic. It lasts 30 to 60 minutes. And so if you're going to use this, try to use this early on in the flight or early on in your transport. So when you get them to the facility, they can be assessed. Their neural status can be assessed by the trauma surgeon or the neurosurgeon or whatever intensivist is going to be taking the patient. So in most circumstances, one dose is going to be plenty. You're not going to be given multiple doses of VEC. So remember, your dose is 0.1 milligrams per kilogram, so standard dose is going to be anywhere from, on most adults, anywhere from 6 to 10 milligrams. And then you're going to piggyback that on top of your sedation and your pain management. Never, ever give a paralytic without making sure they've been given a sedative first. All right, so let's talk about maybe a couple circumstances where you're going to deviate from this protocol real quick. And let's say you get in the back of an ambulance, or you have a patient that's extremely fragile. They're a massive trauma patient. They're vomiting. They're hypoxic. They've got blood and stuff in their airway, and you've got to get a definitive airway right now. Their hemodynamic status is deteriorating, and you've got to make a choice. And so what you can do is do what is called a crash airway. And a crash airway is basically, essentially, you need to get this airway now, and you're going to paralyze them to do that. So what you're going to want to do is you want to skip all those pre-medications. You're going to skip the lidocaine, atropine. You're going to go all the way down, and you're just going to give them a succinylcholine dose. So you're going to give them 1 dose of succinylcholine. You're going to paralyze them. And obviously these patients are extremely sick. And so, we're doing this on very few patients. And once you give them that succinylcholine dose, you're going to intubate them. And then after that, you're going to give them their sedation and their fentanyl. So that's called a crash airway. That's skipping everything. That's in certain circumstances where somebody's very critical and needing rapid intervention. All right, so at this point, we've went through our whole RSI protocol. We've talked about post-sedation management. We've talked about whether we want to use a paralytic post-intubation. Again, just use your judgment. Try to go by the sedation and the fentanyl. If you're an agency that doesn't carry fentanyl, you can use the morphine, but just remember your morphine is going to cause a drop in your blood pressure. So just be cautious of that. Use your fluid. Use a pressor if you need to in medical patients, and just titrate that. But never withhold sedation. Never withhold pain management. It's very, very important. So I want to thank you for joining me on this podcast. I've really enjoyed doing these. And if you have any questions or comments, if you need anything answered, I'm going to be placing things on a blog. I'll do different topics, or I'll do blogs related to these podcasts. I'd love to hear your comments, good or bad. And remember, you can email me at eric@flightbridgeed.com, and I'll talk to you soon.